And are there any reoccurring points in the diagnostic pathway where you see opportunities to streamline or clarify workup for busy clinicians?
So I think the challenge that I can face that I would want to educate other healthcare providers on is um, the involvement of medical oncology early on in the treatment of breast cancer. There are certain subtypes of breast cancer, like the triple negative breast cancers and the HER2 positive breast cancers, where depending on size, stage, other patient characteristics, they may benefit from chemotherapy or other treatments before receiving surgery because how that treatment affects the disease at time of surgery informs how I treat them afterwards. So say a patient has a HER2 positive breast cancer and I over 2 centimeters, I'm oftentimes recommending a combination of chemotherapy and immunotherapy with anti-HER2 drugs. And if at time of surgery all the breast cancer cells are gone, which is called a pathologic complete response, I go down one particular treatment pathway. If there's still remaining breast cancer cells after that treatment, I go down a different pathway that I wouldn't have had access to had we gone to surgery first. And I'm not saying that every patient like that needs these treatments up front, but deserve informed conversations prior to surgery.
Hmm. And when you first meet a newly diagnosed patient, what are the key factors that guide your choice between neoadjuvant and adjuvant systemic therapy?
Oftentimes, the decisions are made for me by the subtypes, the estrogen, progesterone, and HER2 expression. Um, I also appreciate very much my surgical colleagues because there may be some surgical factors that go into whether or not they're eligible for surgery right now or not, or where the tumor exists, if it's close to the pectoralis muscle or, other findings, things like that. If I know that they're going to need these treatments one way or another, and if I can provide better surgical outcomes by doing those treatments up front, I think that that's an important consideration. Sometimes having a multidisciplinary discussion is always going to be helpful to inform those decisions because it's really a team effort when it comes to the treatment of breast cancer.
And how are you incorporating targeted agents like CDK4/6 inhibitors, PARP inhibitors, and antibody drug conjugates in your current treatment algorithms for different breast cancer subtypes?
I can do an entire lecture just on that question alone, and it's exciting. And all of these studies are coming out that are constantly challenging the current treatment paradigms for cancers of all types are being affected almost on a monthly basis, it seems at times. So, CDK4/6 inhibitors work to slow down cell cycle growth, and for decades, the treatment of the hormone receptor positive, HER2 negative, especially stage 2 to stage 3 patients generally, has been hormone blocking treatments. Um, since Monarch-E, which was the study that looked at adjuvant abemaciclib, one of the CDK4/6 inhibitors, showed improvement in patients not having their disease come back. Um, I'm routinely incorporating CDK4/6 inhibitors in this space, not only abemaciclib but also ribociclib as well. PARP inhibitors can be used in select patients that have BRCA1/2 mutations across all stages, except for stage 1. And then antibody drug conjugates are something that we've been routinely using in the stage 4 or metastatic setting, but recently, just in October of 2025, have found a benefit in select patients with HER2 positive disease that remains after neoadjuvant treatment, especially if they're lymph node positive. We're starting to see antibody drug conjugates being used earlier and earlier, and them to have more benefit across a variety of cases compared to traditional chemotherapy.